Good afternoon. As ever, it's a pleasure to be in Trivandrum, meeting all of you again. Even though it's been billed as a miscellaneous talk, it's pretty well the same talk that you've been hearing all through the morning. The agents are the same. The way you use them is pretty well the same. Let me try and see if this situation makes it any different for any of you to use the same agents in a slightly different fashion. What is the logic behind IUI? Why do we do it? IUI overcomes an abnormal coital factor, abnormal cervical factor, and it makes a larger number of sperms available higher in the reproductive tract, several millions in the uterine cavity as opposed to the normal. Usually during normal intercourse, 50 to 100 million sperms are in the vagina, and about 100,000 enter the uterine cavity, and maybe only about 1,000 enter the fallopian tube. So you have a larger number of sperms available in the cavity and better quality sperms available at the site of fertilization. And IUI, along with ovulation induction, improves fertility. But how does that do, and why does it do it? Number one, because the subtle ovulation disorders are overcome when you're using ovulation induction for an IUI. The number of oocytes available for fertilization may be increased, and the time of insemination is also optimized. So these three are the reasons why an IUI might give rise to more number of pregnancies than just a timed intercourse. And what do we want to do in ovulation induction with an IUI procedure? The type of ovulation induction that you do is sometimes named a mild ovarian hyperstimulation as opposed to a controlled ovarian hyperstimulation, or COH, in an ART procedure. So there is something in between when you use ovulation induction for an anovulatory woman to correct anovulation, and in an ART where you use it to produce a lot more eggs. This is something in between. The objective of stimulation here is to obtain more than one, but not more than 4 pre-ovulatory follicles. More than one follicle increases the chance of pregnancy when you're doing the procedure, but less than 4 follicles decreases the chances of adverse outcomes like ovarian hyperstimulation syndrome or multiple births. So your goal is slightly different when you do ovulation induction for an IUI, where you're really not aiming for a monofollicular stimulation. And the chances of pregnancy improves due to, again, subtle ovulation disorders are overcome, increased number of oocytes, and increased better timing. But however, before you start the ovulation induction protocol in any patient, a lot of times when you're in conferences, you're asked, how much do you use? How many units? How do you vary it? And how do you monitor it? Can we have a definite protocol? It goes back to individualizing the protocol in every single time, whether you're doing it in an ovulation, whether you're doing it for IUI, whether you're doing it IUI, the ovarian stimulation has to be individualized. And what does it have to be individualized on? It has to be based, one of the main things is the ovarian function and the reserve. Because the protocols that you would choose and the type of drugs and the dosages that you would use vary depending on this woman is a proven poor responder or somebody in the other extreme like a PCOS. To help you make those decisions, what are the things, the information, pieces of information that you have to have? A baseline FSH level helps, serum E2 level helps, antral follicle counts are very, very important on day 5 or day 6 before you do any type of ovulation induction for any reason whatsoever. Ovarian volume might help. AMH, if the patient can afford, and if you have it, it certainly helps. And a previous ovulation induction track record also helps. Hormone assays, very high levels of FSH result in no pregnancy, and wide cycle-to-cycle variations of FSH also usually result in a poorer outcome. E2 levels, in the presence of a normal FSH, if an elevated E2, usually predicts a poor response. E2 levels of over 800 picograms in women aged 38 and 42, with even a normal day 3 FSH levels, live births become a little bit more scarce. Volume of the ovary, lesser the volume, it could be a poor responder. Very high volumes can be grouped as higher responders. Antral follicle counts, of course, help very much in making your decision. So you make a summary in your own mind of all of these values and decide whether your patient is a poor responder, an average responder, or a hyper responder. Clomiphene citrate, you've heard enough and more in a very detailed fashion in the morning talks, and I don't think I need to get into it, but basically all of us are saying the same thing. The starting dose can be anywhere between 50 and 100 micrograms of clomiphene citrate. in a normal responder and increase by 50 milligrams per cycle if there's no ovulation to a maximum of 150 and usually no more. Doses about 150 produces a decline in E2 receptors and probably more adverse effects. And the common adverse effects that one has to watch for when you're using CC is hot flushes, mood swings, headaches, especially visual disturbances and nausea. Multiple pregnancy rates may vary with what you read, but they can occur with clomiphene citrate. Ovarian hyperstimulation syndrome can also occur with clomiphene citrate in certain situations. Anti-estrogenic effect, it has got a long half-life, and prolonged usage, drug accumulates and has adverse effects like a thin endometrium, which you've heard about earlier, a thickened cervical mucus, which you have heard about earlier, and even ovarian cyst formations. And epithelial tumors has become more questionable. This was in earlier studies where there was a definite link, but yet the watch has to be kept open, and then usage over 12 cycles is not encouraged by any protocol. Gonadotropins, again, you have heard enough about it. FSH or HMG may be used along with CC or letrozole as well as an intermediary protocols, which the minimal stimulation group prefers, but however, it's not a uniform accepted idea where you can use the oral agents with gonadotropins to produce a better outcome. There are groups that like it. There are people who would rather go for a straight to the gonadotropins after failure of clomiphene citrate. And FSH has really theoretically has not proven to have any particular benefit, especially recombinant over HMG or urinary FSH. Dosages, you've heard about them earlier. Complications, of course, when you're using gonadotropins are multiple pregnancies and OHSS. There's one other factor that you have to take into consideration because you're using slightly higher dosages of medications here as compared to what you would do when you're wanting to have a single follicle developing, monofollicular development, and when that happens, the E2 levels are higher and premature LH surges are much more likely to happen. LH surges that precede the triggering of ovulation induction iatrogenically, and LH surge is something where it precedes the triggering of ovulation induction iatrogenically and are premature relative to the planned treatment. It can be rise of LH over 10 IU or a concomitant rise of progesterones as well, which result in luteinization. And the incidence is usually very low in a natural cycle, but it has been calculated to be fairly high, especially when you're using gonadotropins in an IUI cycle. The numbers that have been talked about are anywhere in the order of 22 to 43% of all IUI cycles, where you may get a premature LH surge, which may then interfere with optimal timing of insemination, increases cycle cancellation, and may lead to lower pregnancy rates. Then the question next is, does it benefit then to use something like a GnRH antagonist in an IUI cycle to prevent this premature LH surge from happening? Increasing E2 levels during superovulated IUI cycles, again, the LH surge, increased cycle cancellation, interferes with optimal timing of IUI, and it affects that 22 to 43% of the cycles, whereas GnRH antagonists rapidly inhibit the LH rise, and it can be used in any type of protocol. There have been several studies which have been published. One of the earlier ones was meta-analysis was involved 6 trials with 1,000 and odd subjects, and the higher pregnancy rates were observed in GnRH antagonist timed IUI cycles. However, the number needed to treat to prevent rise of LH was 4 cycles. Number needed to treat to achieve 1 additional pregnancy was 19. The GnRH antagonist for IUI timing, the meta-analysis says the use of antagonists may be justified when an LH, in particular situations where an LH rise is expected. There has been a previous cycle LH rise. There has been people who really want to avoid insemination during weekends in some centers. Older patients with short follicular phase and reduced ovarian reserve may also surge prematurely, may benefit by this. But it cannot be justified universally in all of the IUI patients to increase pregnancy rates. So the conclusion of that was adding GnRH antagonists to control ovarian stimulation may increase pregnancy rates in multifollicular cycles. When you have lots of follicles, similar multiple pregnancy rates but no increase in OHSS, and average total dose is fairly small and results in decreased cycle cancellation rates. When you convert an IUI to IVF because too many follicles develop, GnRH antagonist can be a life savior there as well. Improved intercycle parameters, and then you can move on to an IVF. And however, there have been recent prospective control trials as well. The clinical pregnancy rate for antagonist group after 3 cycles of IUI was 52% with antagonist versus 31% in the control group. Increased number of follicles in the antagonist group and significant reduction of risk for premature luteinization. Cochrane review of 2011, again 6 studies, the recent one quotes that there is no evidence of benefit for adding GnRH antagonist to all IUI cycles. Same authors conducted a randomized double-blind placebo-controlled trial recently, and they didn't find any difference in the live birth rates, significant difference, statistically different this thing between all groups. It does have, on the whole, it does have a slightly beneficial effect if you take all of the cycles, but to conclude, it suppresses the LH surge, does not translate into significant increase in live birth when you use it in all of the cycles, adds to the cost, adds to the complexity of IUI cycles, but it may be used in certain selective situations like we talked about. So at present, the take-home message can be almost completely prevents, no substantial improvement if you use it for all of your cases, and you need to do about 19 to 20 cases with an antagonist to achieve 1 additional pregnancy. And identification of subgroups that may benefit more from GnRH antagonists may be beneficial. And these subgroups may be where women have advanced stage, women with reduced ovarian reserve, patients with previous premature luteinization, and PCOS where numerous follicles are developing, and where you're likely to convert an IUI into an IVF cycle. Weak and free, take it or leave it. I do not want to get into a lot of description about the monitoring part of this thing, but I thought I'll just put some slides up. Follicular studies, HCG administration at 18, IUI 34 to 38 hours later, 2 inseminations or 1 insemination, 2 inseminations 24 and 48 has been tried, but 2 inseminations have not found to produce any better results. Perifollicular echogenicity is something that helps you with timing. Cumulus ovorus may help with the timing, and crenated appearance on the inner lining of the follicle may help you with the timing. Irregular follicular wall and fluid in the cul-de-sac and a fresh corpus luteum tell you that it has already happened. Endometrial assessment helps also. Linear growth should be about 0.5 mm per day, like you heard before. If you're using clomiphene and the endometrium is not measuring up to your thing, it's time to change to another agent. There's no point in adding agents to clomiphene to make the endometrium better, because the problem is at the receptor level. And luteal phase, you can again scan them to see whether the endometrium is proper. There's a fresh corpus luteum, there's a thick echogenic margin, and the Dopplers are okay. Follicular vascularity might help you with your timing as well. Assist with an anechoic thin smooth wall says that something not right has happened. That's a corpus luteum cyst with a solid mesh-like area in between. Thick cyst wall and reticular pattern in a hemorrhagic cyst. Urinary LH surge may be used for monitoring these ovulation inductions, but however, it's not as accurate, not as beneficial as if you can use an ultrasound for predicting. Hormone assays are not mandatory for all cycles of IUI. May be of value in very special circumstances. E2 of over 1,500 increases chance of OHSs and high order multiple pregnancies. More high order multiple pregnancies today occur with IUIs than with ART, because ART you can control the number of follicles, number of embryos which are replaced. Too low an E2, the follicle may or may not be okay. Finally, the success rates in a meta-analysis, the pregnancy rate per cycle is, if you have no treatment at all, the pregnancy rate in that couple might range anywhere from 1.3 to 4, IUI alone 3.8, clomiphene 5.6, clomiphene with IUI 8.3, gonadotropin 7.7, gonadotropins and IUI it's upwards of 17. Even with different factors, the same holds good. When you're using gonadotropins and IUI together, your success rates are far higher than using either one of them alone. Timing is crucial. Number of inseminations does not matter and does not necessarily increase the pregnancy rates. Thank you very much.